I'm an orthopedic surgeon, and I want to spend the next few minutes telling you about a mistake I see consistently in adults over 50. Not a rare mistake, one I see in the majority of patients who walk into my clinic with joint pain that has been getting progressively worse without a clear explanation. The mistake is not what most people expect. It is not sitting too much, although that contributes. It is not skipping the gym, although that matters too. It is something more specific, like a movement avoidance pattern that begins as a rational response to pain and becomes over time one of the primary drivers of joint deterioration in adults in their 50s, 60s, and 70s. I want to explain exactly how this happens, why the standard medical response usually misses it, and what your joints actually need to stop the progression. Most adults who see me for joint pain tell me some version of the same story. The pain started a few years ago, usually one knee, one hip, or the lower back. They reduced the activities that aggravated it. They took anti-inflammatories when it flared. Their doctor ordered imaging, saw some wear, said it was normal for their age, and the pain kept progressing anyway, even though they were doing what they were told. Here is what I want you to understand. If that story sounds familiar, it is not because you failed to follow instructions. It is because the instructions were incomplete. What I'm about to explain is almost never part of a standard 15-minute appointment, and it should be. If you are over 50 and you have chronic joint discomfort, even mild, even intermittent, stay with me through this entire video. By the end, you will understand something about your joints that most people in your situation have never been told. The mistake I am describing starts with a concept called movement compensation. When a joint becomes painful, the body automatically shifts load. If your right knee hurts, your gait adjusts within days to reduce the force going through that joint. Muscles on the other side work harder. The hip tilts slightly. The lower back absorbs more rotation. Short term, this is intelligent. Long term, it is the beginning of a cascade that affects joints well beyond the one that first started hurting. Here is what that cascade looks like in the body. Articular cartilage, the smooth tissue that covers the ends of your bones inside every major joint, has no blood supply of its own. It gets its nutrition through compression and release. Movement pumps fluid through the cartilage matrix the way squeezing a sponge cycles water in and out. When a joint moves through its full range under appropriate load, the cartilage gets bathed in synovial fluid, the joint's natural lubricant and nutrient delivery system. When that movement is replaced by compensatory patterns, certain regions of the cartilage stop receiving adequate nutrition. Gradually, over months and years, research published through the American Academy of Orthopedic Surgeons documents what follows. Cartilage in underloaded regions begins to thin. The bone beneath it remodels under altered stress. Pain receptors grow more sensitive. And the joint that started hurting first is often not the one that causes the most functional limitation 5 years later. It is the joints that absorb the compensation that show the steeper decline. The most common error adults over 50 make when dealing with joint pain is restricting movement globally rather than modifying it intelligently. They stop walking as far. They avoid activities that cause flares. They become afraid of their own joints. And that protective avoidance, maintained over months and years, creates the exact nutritional deficit in the cartilage matrix that accelerates the deterioration they are trying to prevent. I want to say that clearly because this is the core of what I see in my clinic. The instinct to rest a painful joint is correct for acute injuries and active flares. It is harmful as a long-term management strategy for chronic joint discomfort in adults over 50. The biology does not support rest. It supports appropriate, consistent, modified movement. If what I have said in the last few minutes resonates, take one action right now. Click subscribe. And if this kind of explanation has been useful, hit the like button. This information should not live behind a clinic wall. The algorithm needs your signal to get it to more people who need it. Now, let me walk you through what intelligent joint management actually looks like for adults over 50. The first principle is load distribution through range of motion. Every major joint was designed to move through a specific arc. When we consistently use only a portion of that arc because pain or stiffness has narrowed it, we starve the portions of cartilage that correspond to the neglected range. The practical application is not complicated. Daily movement that takes each joint through as much of its natural range as it can currently tolerate without forcing, without added weight, without impact. Slow, controlled, deliberate motion, not exercise in the traditional sense, joint feeding. The cartilage regions that have not been reached in months are not destroyed. They are undernourished. Restoring range is not rehabilitation. It is basic maintenance. The second principle is load management, not load elimination. One of the most damaging recommendations patients receive is the instruction to avoid all weight bearing activity once joint wear is visible on imaging. The logic seems sound: less force, less damage. But cartilage needs compressive load to maintain structural integrity, not impact. Gentle distributed compression, walking on a flat surface, standing and shifting weight, sitting to standing. Research in the Journal of Orthopedic Research has consistently shown that cartilage in non weight bearing joint regions deteriorates faster in sedentary adults than in those who maintain low impact daily activity. The joint does not benefit from being spared, it benefits from being used correctly. The third principle, and the one most directly tied to the mistake I described at the start, is managing compensation actively rather than letting it accumulate. If pain in one area is causing you to move asymmetrically, that compensation is producing uneven load on every joint above and below the original site. The intervention is not treating the compensatory joints. It is restoring as much function to the original site as possible and maintaining bilateral symmetrical movement patterns in daily activity. Asymmetrical loading maintained over years produces asymmetrical wear. That is not a metaphor, it is the biomechanical mechanism. For a long time, when patients needed structured guidance on managing joint movement at home, I referred them to physical therapy. That is still the right recommendation when someone has the access, the insurance coverage, the transportation, and the schedule to follow through. In my experience, a significant portion of the patients who need it most do not have all four of those things aligned at once. I spent years giving people the right advice and watching them leave my office and do essentially nothing, not from lack of motivation, but because the path between the advice and the action was too long and too expensive. I resisted digital alternatives for years. My concern was specific: patients with joint pain, particularly older adults, risk doing the wrong movement the wrong way without a clinician watching form. Without that oversight, I did not trust the outcomes. What changed my position was a practical observation about which patients were actually improving. The common thread was not the sophistication of the intervention, it was consistency. Patients with a clear, structured daily sequence they could follow at home were showing better functional outcomes at 6 months than those prescribed intermittent programs that required more coordination to access. The program I eventually started recommending organizes daily joint care into short sessions, 5 to 7 minutes, using an illustrated library of low load movements designed for each joint region. No equipment, no gym. For patients with unpredictable flares, it includes a flare up protocol, not a rest instruction, which is what most people default to, but safe reduced intensity movements that maintain joint circulation and range on high pain days without aggravating tissue. That component addresses directly what I described earlier: the dangerous tendency to stop all movement during a flare, which is precisely when the joint most needs modified motion. I have been recommending this to patients between 60 and 72 who fit the profile I described at the start: chronic discomfort, movement restriction, compensatory patterns, not currently in physical therapy. In that group, consistently enough to keep it in my recommendations, I see measurable improvement in functional range and reported pain levels within 4 to 6 weeks. Not in every patient, for some, more intensive care is necessary. But for adults with moderate chronic joint discomfort who are not actively receiving structured guidance, daily movement at home produces results that unsupported activity does not. The link is in the description below if you want to look at the structure. Joint health after 50 does not exist in isolation. When pain restricts movement, the downstream effects accumulate quickly. Muscle mass declines because the loading that maintains it stops happening. Balance deteriorates because proprioceptive signals from guarded joints are weaker than from mobile ones. Cardiovascular conditioning decreases because the activities that sustained it become too uncomfortable. One avoided joint over 2 or 3 years can reduce functional independence across multiple systems. The adults who maintain the greatest functional independence into their 70s and 80s are not the ones with the least wear on imaging. They are the ones who responded to discomfort with modified, consistent movement rather than protective stillness. I have patients in their mid 70s with significant wear on their films who sit down and stand up without assistance, and patients 15 years younger who cannot. The difference in most cases is a decade of movement decisions. Tell me in the comments which joint causes you the most trouble during everyday tasks: getting in and out of a car, climbing stairs, getting up from a low chair, and how long that has been limiting you. The cartilage matrix in a joint that has been partially immobilized adapts to that restricted state And reversing that adaptation takes longer at 68 than it did at 58. Every week of maintained compensation represents cartilage that has gone a week longer without adequate nutritional cycling. The biology does not pause. The program I mentioned organizes daily joint maintenance into something you can follow consistently: short sessions, clear structure, a flare up protocol for the hard days, and a progressive plan that removes the daily decision about what comes next. The link is in the description and in the pinned comment below. What I'm sharing here is education, not a personal diagnosis. If you have a specific condition under active treatment, talk with the physician who knows your history before changing your movement routine. That is not a disclaimer, it is the correct clinical instruction. The patients I have seen recover the most functional capacity over time share one characteristic: they began structured movement before restriction became the new baseline, not because they were highly motivated, because they had a clear sequence to follow on the days when everything hurt and motivation was unavailable.